Hey folks, Scott Weingart here, and this is the EMCrit One-to-One Nursing Podcast. This is the inaugural episode. This is number one. You are part of history, and I think we have a great episode for you. We're going to go through a case and discuss various things that come up. I am joined by Candace King, the administrator for ED nursing at a major level 1 trauma center. And I think you're really going to enjoy it. Let's dive right in. All right, you ready?
I'm ready.
All right, let's do it. We are back for another episode of the One-to-One Nursing Podcast. In fact, this is technically our first episode because the other one was just a little intro. So this is the first real episode. How does it feel to be here, Candace?
Oh, it feels lovely. I couldn't help myself I heard that there was a lot of very positive feedback. I'm going to be honest. I probably have to get over the challenge of listening to myself because that seemed a little strange.
Yeah, it's hard. That takes a while. But yes, people are very excited, and we will not disappoint because this is going to be a great episode. You have no idea what we're talking about.
No, you never give me any information. Right. I have to go in like naked to these things.
Yes, but since it's audio, she is not literally naked. So
I have on a very nice pink shirt.
That is correct. All right. What we're going to do an easy case of sepsis. It's not going to be a stumper. I'm not exaggerating. This is like legitimately just bread and butter septic case because I think there's a lot of stuff that will come out of it that may be done differently in your shop than others and maybe a great opportunity for us to reiterate the optimal care of these patients. So this is a 70-year-old male. He's been feeling sick for a few days. And he finally just really did not look good. His wife called an ambulance. He was brought into triage. He was tachycardic at 132. His blood pressure, it was okay, 110/70, not a big deal. And he was breathing like 22 times a minute, like a legitimate 22, not just an imaginary. We just wrote that down because it's easy to write. Because that number always, Candace, would be?
16.
16, that is correct. So we know if it's not 16, they actually looked at his respiratory rate. And he's satting like 94%. That's a room air sat. And I think at Janus General, he would probably be put in the critical care area just for that tachycardia. Is that correct?
Yes.
Yeah. Now, if you were in a ED that didn't have critical care, this would probably just be a bread and butter, like whatever their regular medical zone patient is. Does that sound right?
I think he would just be mixed upon the, what do they call it in most places? Like main department?
Yeah, the main department, exactly.
But the 94 SAT isn't great either because you're saying that's on room air. Is he febrile?
He is. You guys do an oral temp and he's 102.4.
Okay.
All right. So
then his triage would be in the high acuity space regardless of his past medical history for vital signs alone.
Yep. All right. So this guy meets SIRS criteria. He's a potential septic player. So he's going to go to a high acuity area or in our case, a critical care area. Now, this patient wouldn't be put in a resus room. He'd be put in a regular room. And one of the things that I loved at Janus General was that you folks work on a swarm model where the patient's announced overhead and a doc, usually a resident at this stage of the game, would come in. And if they were available, multiple nurses would come see this patient at once. Tell me about the philosophy of that, Candace.
So we all know that the beginning stages of the patient's care, like 85% of it is done in the emergency department prior to admission to begin with, right? But really, even beyond the amount of stuff that's done before admission, a large majority of that is done in the first 30 to 45 minutes, right? Between venous access, laboratory values, point of care testing, EKGs, all that kind of stuff. And that's not really feasible to be done by one person. And team nursing allows more of a global perspective, even that maybe Candace thinks about it one way and Dana thinks about it another way, right? But we both bring something to the table. In addition to skill sets are different, right? Skill sets amongst each person. Maybe I'm struggling with putting in the IV that day. This is a patient who has particularly difficult access, and my partner, whoever that may be, might have been successful, right? And it allows you to do a lot more tasks at one time and capitalize on the first 10 to 15 minutes of their arrival. So that's our philosophy is one is it gains camaraderie between the team, right? When you work in our critical care area, there's more than one physician, so there should be more than one nurse. It's not going to be a group of physicians and one nurse carrying out the tasks that they're asking for, but rather the same complement of staff so the tasks get done in a priority that is meaningful to the team globally.
I love it. All right. Now, at this moment, one of the nurses is drawing blood while the other nurse starts interviewing the patient. And a big sea change for me was all of a sudden I was seeing nurses drawing blood from the existing EMS IVs. And I had never seen that before. And it was a game changer because for almost every patient, they were able to get blood from these IVs. It was much more rapid. Was this something instituted during your time, during your tenure? What was the philosophy behind this?
We integrated really point of care testing. And in order to do that, we wanted to ascertain the blood samples quickly. We started using the EMS access. You're already going to test the line for its patency. Why not draw the samples off of it? Now, aside for that, you're not going to draw blood cultures off of that because that's contaminated. You have no idea how it was put in. But there's no reason why you couldn't draw your point of care labs off of that and then whatever additional specimens you're going to do. But I don't typically suggest drawing them through a syringe and then using a transfer device into the tube. I suggest that you put the vacuum container, whatever product you're using, directly on the hub of the IV and draw directly into the tubes, right?
Hey, so this is Future Weingart. I'll be popping in periodically to add some stuff or to disambiguate. And so in this case, I want EMCritters, whether they're nursing EMCritters or physician EMCritters, to question everything you hear. Just because we're telling you, just because a doc tells you, just because someone from the education department tells you something, don't trust it. Listen, take it in. Don't be recalcitrant to their face, but don't take it into your inner system of knowledge until you've vetted it, until you've made sure that what the people are telling you is actually correct. So in this case, we mentioned that you can draw bloods from an existing IV line placed from EMS or by one of your former colleagues on another shift. And you should say, that's interesting. We haven't been doing that. And don't just start doing it tomorrow. You got to find evidence to support it. Now, in this case, the evidence is in the show notes for this episode. You can find a systematic review demonstrating that it's no worse to draw from an existing line like the one from EMS than it would be from you having placed a fresh line in the course of working up a new patient. You place a line and you attach the vacutainer hub to that and draw off your bloods for everything except blood cultures, as mentioned. Now, you obviously have to waste some of that blood. 2 mLs is the minimum. And after that, you're going to get like results as to the ones you would get if you had just placed that IV fresh. So there's evidence for this. And so if you're going to start doing this, obviously make sure it's okay in your existing protocols or talk to someone in your education tree and say, is this okay? Now, you said they test the patency of this. How do they actually do that before they start drawing blood?
So we use a clave adapter on the end of each one of these lines. Certainly you have to clean it aseptically. And then we typically just flush the line with like a high frequency saline flush. And then after that, draw back the waste, right? So that you have nice blood return in the peripheral IV, like tubing. And then from there, we draw the sample. So you're not having any waste product there. If you are confident, like the patient's already receiving a fluid bolus or something like that, and you're comfortable and confident with the patency of the IV, then you can certainly stop the IV bolus and draw a waste tube. But I would recommend that you draw at least one of the very large waste tubes.
Now, we have had a few issues, very infrequently, but we have had a few issues where they were drawing blood from EMS lines that were above other lines in which the patient was getting
Oh, yeah.
infused fluids, and then the labs look really scary. So if you're going to do this, obviously, you should make sure that is the most distal of the things the patient has, or that you have stopped whatever is below it. and let some washout time occur and then make sure the wasting is really occurring at the amount of blood you've indicated.
Yeah, so most of EMS is already infusing volume. We would stop it, right? Because one, it gives you accuracy of how much they got prior to arrival. And then two, there's no risk of anything being mixed in your samples, right? And whether or not you choose to use the rest of that fluid bolus to account for the volume is fine, but you either need to account for it in one way or the other, right? Are you going to account for pre-hospital fluids? Then it's just pre-hospital fluids, but you can't add the pre-hospital fluids plus add that to your normal bolus. So you have to be meticulous about which volume of fluid you are allotting there. So for me, I typically recommend that they stop everything completely so that there's nothing infusing at the time. Certainly, we take our EMS vasopressors, and we may talk about that differently, but we stop those and remake our own. It's a different concentration, and it's not here in our community. They don't use pumps. It's more of a antiqued dial-a-flow method, and it's not always communicated well on the dose.
Yeah, and plus, trust no one, right? Like we didn't
Right.
make that infusion,
I don't
so
trust
we don't
anyone
know
anyway.
exactly what's going on there. It's you just take those variables out. All right, but back to the blood draw. I've noticed, and I've always appreciated that the nurses would just draw everything. And it doesn't mean they're going to send everything, but they just, at that first blood draw, they would have every possible tube we would need, well, except the blood cultures, because that's going to be done through a fresh line. And then we'd be like, oh, we forgot to send. And they'd be like, all right, no problem. We have these tubes. Is that the philosophy you're teaching, or they have just adopted that themselves?
No, so we teach that and we really partnered with the lab. So now we send all the tubes,
Mm.
regardless if you need them or not, down. So whatever bag of blood you're sending will have all the tubes in it. So say we typically draw two mint top tubes. We only need one, but we leave the other one reserved just in case you add a hepatic panel or amylase lipase or something along those lines. Sometimes we need ammonia levels or something like that. And those are extra tubes, but I prefer that they do it all at the first time. Then the lab keeps the unordered tubes or unnecessary tubes down there for about 3 to 4 hours post the initial draw. And they will then use an add-on process. So you can always use the initial lab draw to calculate whatever values you're looking for.
I love that. That's an amazing thing. I've never heard of that, the lab actually holding them rather than the ED having to. So that's fantastic. All right. And then after the blood is drawn, our nurses would always get a second IV on an actually sick patient. And they would always just grab 18 gauges. And this was another real change I've seen where a lot of the nurses in the ED would just 20 would be the baseline and 22 would just be done without even thinking about it. Oh, these veins look small. I'll put in a 22. And then you try to resuscitate a patient who got sicker and it would be a real crap show. An 18 gauge is like, that's all you really need. I don't even want a 16 gauge because of the risk of blowing those vessels. Why is the IV game so good at your place? How did you get there? And how do we convince regular ED nurses that sick patients need bigger gauge IVs than 22s?
One, it's in the stocking of the cart, right? So when you open the drawer to get out your IV supplies, the first one you're going to see is the 18 gauge, and then the 20 gauge, and any 16, 22 are kept in the back of the drawer. So it's visually appealing that you'll make that selection. We put into practice that a 22 gauge is for pediatrics. So if you don't have a pediatric patient, you shouldn't be using that because we do see adult and peds in the same space. And certainly there are the elderly population that it's more challenging, but and that might be at the time that you reach for a 20 gauge. But the standard person, if you can get a 20 gauge there, you're likely to get an 18. The difference is when you use the product that we have, the flash return is different. It's different on the 18 than the 20, and it's all about repetition, right? So the more you do it, the better you'll be, right? And when there's younger trauma patients, that's the population that we tend to see. That's your opportunity to really get in there and use that because their veins are large and healthy, and you want to make sure that you're successful at those before you start with the elderly person that perhaps has more fragile vasculature. But it's really the standard of that's your option. It's visually there for you to direct you in that way. I agree with a 16 gauge IV. I don't know why you need such a large one. I get it for volume resuscitation, whatever, for mass trans or GI bleed or something along those lines. But I don't think you need that for the standard sepsis resuscitation or the COPD exacerbation. I don't think you need that.
Absolutely. And maybe it's a whole separate show on upping IV game because I think people really need that in many cases. And so this patient gets started on fluids. What fluid do you folks stock as your standard IV fluid?
So quite some time ago, we swapped over to LR exclusively at the bedside. So there's nothing but liter bags of LR in, again, the same bedside cart. And it's a pretty large cart shared amongst 1 to 2 patients in these large rooms. And that's what's in there. On the rarity that you need normal saline, there are 500 bags in limited quantity, maybe 4 or 5 in the same drawer. But we changed the volume size to alert you that you're using a different fluid choice than if you were going to go with your traditional lactated ringers. But most patients will get boluses of lactated ringers, and they all come in liter bags.
All right. This patient's already febrile, but if they weren't, but with the same story, coughing, feeling sick, vital signs are a little sursy, and an oral temp that was supposedly normal, did the docs have to ask for a rectal temp, or are the nurses just empirically doing it, knowing there's a gross inaccuracy of these oral temps?
I think that depends on the person, to be honest with you. I think that overall it's doesn't make sense in the presentation if the person doesn't have a temp, right? If you especially know why they're there, right? Which this is all pointing in one direction. Maybe they have pneumonia, right? So it doesn't really make sense. So I would say that they would primarily get their own rectal temp and have that conversation with the physician. I'm not sure that, and this is an afebrile case, so I got a rectal temp and this is the result. And then there's some docs that are just rectal temp kind of people, and they always want that because they feel as if it's really imperative to their diagnosis. But overall, I would say that the nurse does it themselves.
Future Weingart here again, and I might be making some enemies amongst my nursing friends here with this one. But oral temps are inaccurate, especially in the elderly. Now, if they're already febrile on their oral temp, obviously they don't need a rectal temp. But if your spidey sense is tingling that this could be infectious and the oral temp is normal, even if it's like, oh, no, I'll do it if it was 100.3, of course, but I'm not going to do it if it's 97 on the oral. It can't be that inaccurate. No, it can be that inaccurate. And unfortunately, you got to get rectal temps if you want to know what the patient's core temp actually is. And so even though it's annoying, even though it's not fun for the patient or for whoever's doing the rectal temp, it's got to get done if you actually want to know if the patient is either febrile or, just as importantly, hypothermic. So I put 2 papers in the show notes. I'm sure there are more. And I just had a case the other day with a patient who had a normal oral temp, and we got the rectal temp, and the patient was actually profoundly hypothermic. So it could go both ways, and you can't trust those oral temps. Sorry. So this patient, everyone knows what's going on. They get a point of care x-ray, and it shows a big left-sided pneumonia. Again, not news to anyone. And the doctors order antibiotics. And they feel for whatever reason this patient's a little bit sicker. Maybe there's something in his history. So they order ceftriaxone, Zithromax, and vancomycin. Now, the standard teaching, Candace, is you cannot give simultaneous antibiotics. I disagree with that standard teaching. What are your feelings on this?
I feel like now we do so much weight-based Vanco, and then it alters your floor stock volume, right? Because we stock 1 gram, and if they're ordering 1.25, then I think you got to wait. But say everybody's getting just the standard doses, right? Pumps are a rarity at our hospital for whatever reason. There's millions of them, but our colleagues on the inpatient unit like to hoard them and put them in their closets upstairs. Down in the ED, we do some non-traditional pump management. So my philosophy is a small volume of fluids gets free hung for 15 to 30 minutes, and then a large volume of fluid needs to go on a pump. So ceftriaxone typically comes in 50 mLs, right? So you'd hang that, then you'd walk around and get your pump. You'd come back, that should be over, right? And then you would hang, it's really sequential antibiotics. Then you'll hang your Zithro, then you'll hang your Vanco, especially if it's coming from pharmacy. Now there's the big question of, can you hang Zithromax and Vanco at the same time? So how do you determine an allergic reaction if you do that?
That is the classic teaching as to why you shouldn't.
Right. I've
I
never
would
seen it
argue,
happen. I'm going to be
yeah,
honest,
it
right?
doesn't
Like
happen
I've,
very frequently. If it did, okay, then we could simply say this patient may be allergic to either Vanco or Zithromax, and we could figure that out later. But what has taken place is the patient has waited on antibiotics that may be the only ones covering the bug they have. And on a patient, they just come in, they're like a regular cellulitis or what have you. It just doesn't matter that much, the rapidity of antibiotics. But on the other hand, on sick septic patients, it might. I think risk benefit would tell us just get the antibiotics in as quickly as possible on patients who are really sick, and then stick with the regular teachings of non-simultaneous antibiotics on the ones who aren't really sick. Does that seem fair?
yeah, I think that seems fair. I've never really seen in my 20 years here somebody have a true allergic reaction.
Yeah,
Like you get a little red band syndrome from your Vanco. First dose, it's rare.
absolutely. Now, this patient, the docs order a liter of IV fluids, and there's some consternation about that, but the patient does not actually meet criteria for septic shock or severe sepsis. Now, there's a misunderstanding in many places that every patient with sepsis needs to get 30 mLs per kg. Or what has happened, and this one's really distressing, is the hospital has just said, we're not going to get dinged. And even though it's only patients with a lactate greater than 4 or hypotension that needs this 30 mLs per kg, we want everyone to get it. And that way we won't have to worry about it. We'll just give every single septic patient 30 mLs per kg. What is your take on that, Candace?
I don't agree with that, right? And I know everybody has their own opinion on what you should do at volume resuscitation, but I don't agree with that, right? I think that if you want to give some volume replacement, because I believe the basic person is slightly dehydrated, the elderly are more than that. I think that's okay, but I don't believe that you need to give a true volume 30 cc's per kg, number one. Number two is the American population is not the thinnest, right? So I think you could use ideal body weight if you're going to make that calculation. And then number three is I think sometimes fluids can cause harm, right? And I think people forget that. These people patients are pretty vulnerable, and I think the volume sometimes can hurt them. And I don't necessarily think that is the best for them. I think we're very lucky that we have point of care lactate. So you're able to get that back in 2 to 3 minutes after the specimen is running on the point of care machine. So it helps you in that stance, gives you an edge. I don't think that every person needs to get copious volume amounts of volume. Like we used to do that. We used to give 6, 7 liters, and it was made no sense because then you're chasing all this diluted blood, right? And it takes away from the global picture of the patient. And they wind up not doing any better. So
Yep.
why would you do that?
Yep. Couldn't agree more. Popping in again here just to say I could do an entire soapbox episode on why the American sepsis standards through CMS are flawed, are not evidence-based, are not saving lives. Quite the contrary, are potentially deleterious. I'm not going to do that here. I just want you to understand that even though we, as hospitals in the US, all follow these regulations, these guidelines, it doesn't mean they're right. It doesn't mean they're correct. It doesn't mean they're evidence-based. And maybe we talk about that on a future episode. All right. In your shop, what nursing ratio would this patient get?
This patient at the
Yeah,
beginning would have
at the
two
beginning.
nurses, obviously, until the workup is done,
Sure.
right?
But once
Um,
that's settled
and then
down,
once that's settled, they're about a 1 to 3,
okay, 1 to 3,
1 to 4,
very
if
reasonable.
they're stable, right?
Yep.
If you've gotten over that hump. But if they're on pressors and need non-invasive
Well,
respiratory work,
yeah.
oh, okay, sorry.
No,
But
not at
I'm
all.
going in
Yeah.
naked, remember?
Yeah.
So I have no
No,
idea where you're going here.
absolutely. But right now, it sounds like a 1 to 3, 1 to 4. In your ED, in many EDs, this patient might be a 1 to 6 or 1 to 8, even though that's clearly not cool.
Yeah, totally. And that would be like with the quote unquote main department. So I think that ratio of 1 to 6, 1 to 8 is appropriate for moderate acuity patients, but this isn't a moderate acuity patient. So it should be 1 to 3. Emergency medicine, it's really hard to be on a 1 to 1 ratio just based on the high acuity of your ED.
Absolutely. All right. And now this one is one I'm curious about. How often would a patient, as described, get rechecked?
Oh, so our standard in the critical care ED is that you have Q1 hour vital signs. And that's at least until the first quote unquote shift, we'll say, like 12 hours or so, because then you're able to determine whether or not they're going to change the game halfway through. And then we have tons of tasks that is done simultaneously. So you would expect that the nurse is in the room hourly. Our space is quite large. And we try to put people in one concentrated, we don't necessarily give them districts, right? It's team nursing, and you make a decision where your complement and acuity and what your workload is. But you certainly shouldn't pick somebody on one side and then all the way on the other. Somebody's going to get ignored, right? So we try to encourage them to at least group their patients together so that they have the opportunity to be there, walking past the bedside, pulling in the vital signs, hanging additional medications, drawing additional blood samples, right? That should be 60 minutes and nothing less than that.
Hey, future Weingart here. Just saying, completely understand about the Q1 hour vital signs as a standard. As the doc in these patients, I will tell you, I sneak in. I change the vital sign rep time to something like Q10 or Q15 minutes at the beginning stages before the patient goes on vasopressors. And I'm in that room at least 3 or 4 times an hour. I do rounds on all of the patients I'm covering. I just walk around and take a look at them, and I will look at those vital signs on these septic patients because, as mentioned, their vital signs have these fluctuations, these drops and rises, and I don't want to miss it. So even if the nurses are only looking at these patients Q1 hour, I'm trying to look at them far more frequently. And I think if they're your patients and you're not involved in other tests, it's worth just peeking up at their vital sign monitor and having the vital sign rep time at a frequency that will allow you to see these dips and rises. And that's incredibly fair and better than almost any ED out there, I imagine. And yet it scares me in patients like this because their vital signs have a tendency to fluctuate. And in fact, this guy's do fluctuate. And what happens is in the second hour, he has a little drop, his map winds up 66, and then the nurse recycles and it's back up to 75 on a map. And this fluctuation happens for a couple hours. And then they walk into the room again, and now his map is 52. Obviously, he's had some worsening over this point, and his initial lactate was 3.5. So he doesn't quite meet that cutoff. But obviously, this guy, by vital signs and by that blood marker, is telling us he's a little sicker than your run of the mill septic patient. And now he's actually on recheck again. He's actually hypotensive, 52 map. What's going to happen at your place at this moment in time, Candace?
Okay, so if he is now hypotensive and we gave him 1 liter of fluid,
He had one
I
liter of
think that's
fluid,
what you
correct?
said. Right. I'm assuming, how much does he weigh?
Let's say he's your typical 70 kilo,
Okay.
that rarity.
So one, I think that we would make sure that he make a decision. Is he going to get more fluids based on his volume status? How long has it been since I think you said a couple of hours,
Yep.
right? Since the first one. So if the lactate, our point of care lactate was originally 3.5, I would assume we gave that volume of fluids. And I try to tell people, like, you don't have to repeat the lactic at hour 3. If you gave the fluids, repeat it now.
Mm.
One, you're setting the nurse up for failure if you're saying it needs to be done by 11:28, because at 11:20 she's going to be in a mass trans, right? So nobody cares about that. You gave the volume resuscitation, right? Repeat the lactic. If it comes back at 2.7, you know you're still doing it again anyway. So what's the difference? But at least you know you're trending in the right direction as opposed to trending in the bad direction.
Let me pause you
So
there, Candace, and clarify that. What is the new reg? I thought all we had to do is send a second lactate. Is there some number you need to hit?
So if it's greater than 2, we repeat it. That's the new rec. If
Oh,
so,
wow.
if there's a lactate greater than 2, you must repeat it,
That's
right?
kind Now, Candace said this perfectly, but I just want to make sure it is really clear. So, the newest iteration of the CMS guidelines, the SEP1 guidelines, says that if the lactate is greater than 2, there must be a repeat lactate. That repeat doesn't have to be any particular number. You don't have to do anything. You don't have to give fluids if it's just greater than 2 and not greater than 4 by these guidelines. And in fact, now you don't even have to give fluids if it's greater than 4 if you specify something along the lines of what the patient's volume status is and why you think they'd be harmed by that. But if it's greater than 2, you got to repeat it at least once. It doesn't matter what the new number is. Now, just to say, I don't know where they got this value of 2 meaning something, why that's when you have to repeat it. There's, again, no evidence for this. This is just out of their butts. The other thing I wanted to say is the way the vital signs often work in sepsis is this roller coaster where the patient drops their map and you're like, oh, they're hypotensive. Let me recycle it. Maybe it was just a wrong reading. And then the next one is normal. And you're like, oh, yeah, it was a wrong reading. Everything's fine. No, everything was not fine. What happens is the patient drops their blood pressure and then they get a spike of endogenous catecholamines, their own epinephrine and norepinephrine, and their blood pressure goes back up. So when you recycle it, it looks okay. That is a patient who will continue to cycle downwards, and each subsequent drop will be lower, and each subsequent recovery from their endogenous catechols will be less of a recovery, to the point where if the patient's maps are like 50 and then you recycle and it's 70, and then the next time they're 46 and then they're 62, eventually they're going to get to the point where one of their dips, one of their naders is below 40, and then they have a risk of sudden cardiac arrest. And that's how a lot of patients with sepsis die. So as soon as you start noticing the roller coaster, a good nurse will say, my spidey sense is tingling that this patient may need vasopressors. Maybe I start talking now, even though those maps come back up. Maybe I start talking to the docs now. Hey, could you put in a PRN norepi order for, map of less than 65, start vasopressors, and then you'd have it. You could even have it in the room. You could even, if you're in an upstairs place, have it sent to you so it's ready at the bedside, because that's where this patient's going to go when they're doing these cyclical dips and recoveries. They're eventually going to start bottoming it out at really scary places. They just keep making it worse. Okay, so now we know that. All right, so this patient, you talk it over with the doc, and the two of you together decide you just want to start this patient on some vasopressors, even though they're going to get the more fluids to make up the 3 liters. And you run peripheral vasopressors. Tell me about
Yes.
that and who you would do it on, who you wouldn't do it on.
So we always start our vasopressors peripherally. I don't think that we would wait in any stance for a midline or a central line to go in. I think also if you are assessing your vasculature before you start them, then you're confident in what you put in there. But we typically do peripheral vasopressors for Levophed, for Neo, pretty much everything but vasopressin.
Yeah.
That's the only one we won't do. But overall, and we have no time frame either. I know people believe, oh, I started it peripherally, but I only got an hour. Yeah, that doesn't exist. A lot of things can happen in an hour. Emergency medicine is about being dynamic, and you can't have a time frame to everything. So I would say it's not well received when we send patients elsewhere with peripheral vasopressors after 12 hours or whatever, but it's definitely what we do. Especially if you only need a little bit to get you over whatever's going on. You gave those antibiotics, you need them to work a little bit. You maybe gave a little bit of fluids, corrected some electrolytes, whatever. I think that it is better for the patient than getting invasive procedures, whether that's going to be a dirty line or a clean line. If it's a dirty line, they're going to need another one, right? It adds a different variable to their stay.
So this patient goes on 5 of norepi. The map is now 69. The patient gets the rest of their 30 mLs per kg of fluid load. And so what ratio now should this patient get?
Typically, we would say if they're sticking around with their vasopressors and it's just vasopressors, I think they could stick to their 1 to 3. If it's it doesn't require aggressive titration, I think that's fine. I definitely wouldn't go any higher than that. Unless the patients that you have are boarding medicine patients that don't need a lot of care or attention. But for the most part, they usually stick to a 1 to 3. I'm
Are the nurses good?
pretty
Okay.
strict about I don't allow, like, I get nervous when there's more than 24 patients in that space, knowing that there's 6 nurses and a lead nurse. I feel like then I need to add more staff to that plan.
That makes sense. Is this patient to be rechecked more frequently than Q1 hour now?
We have a standard that, like, your vasopressor utilization with peripheral IVs needs to be looked at quite often, right? I think that they would reset, at least myself, would reset the vital signs to probably be Q 30 minutes on the monitor. The other thing about our space that's really good is we have mirrored monitors that are up on the walls, right, on the outside of the corridor. So you can see if there's something abnormal, plus the same concept at the attending desk. So they have the option to be able to see if there's vital signs that are abnormal. I think that you might want to look a little bit closer at that. You want to make sure that the pump is facing the doorway of the room. They're very large doors, so at least you can see if there's an issue. And there's safety mechanisms on the pump, but I would say every 30 minutes is 30 minutes to an hour is how we need to look at these sites, especially if it's peripheral.
All right. Now, this patient unfortunately gets worse. And on the next nursing recheck, he just doesn't look like he's breathing very well. His SATs have gone down from the nasal cannula he was on. He was doing okay. He was satting 96 on the nasal cannula. Now he's satting in the 80s, and he's a little bit obtunded. Nursing assessment is he's going the wrong direction. And so you get the docs and you huddle about what to do. And the docs say, I think at this point we have to intubate this patient. Are these patients going to be intubated in situ in the regular rooms, or are they going to be brought to a recess room for the intubation?
We typically do our intubations in the recess room because that's not really a procedure we want to do. One, with somebody next to you, or two, without all of the equipment. Certainly the equipment has wheels, and if there's other people in the recess room, you can move all that stuff. But moving all the stuff versus moving the patient, I think it's tends to be easier to just move the stretcher, right? Where you have your difficult airway cart and your video tower and all the things that you need to do your intubation.
Absolutely. Now, the vital signs, the patient's now on 10 of norepi and his MAP is 66. What's going through your mind as this patient's about to be intubated with that MAP?
Yeah, that's not a good map, right? You're going to intubate this person, they're only going to go down as a result of the intubation. And for me, 60 is really not the number, especially if it's not, I'm not chasing volume. There's no volume loss here that I'm like running after. Like for me, 60 is not it. I would go higher, like
All right.
significantly higher,
What MAP do you want right before an intubation?
at least 75.
That sounds good. All right, we're not going to go through the entire intricacies of the intubation and everything that goes along with that because that's another show in and of itself. So, this patient gets intubated, and the docs ask for a bunch of stuff in the midst of the intubation. They ask for intubation meds, and then they ask for the patient's sedation, and they ask for vasopressin to actually be added to the mix, and they want some steroids. And this is all going on in the recess room. Now, I've been in places where the nurses just say, yeah, I'm not doing any of that unless you put those orders into the computer. And you can't see Candace's face right now, but she's aghast. And that obviously doesn't work. But by the same token, we don't want to have verbal orders going astray, especially this patient. They order some opioids for the patient's post intubation sedation. How do you work this to make a nice compromise between being able to get things done and having documentation and not having nurses hung out to dry from things like opioid orders or maybe ketamine for the intubation that never get put in the computer?
Yeah, I think those are the only drugs that really make me uncomfortable is ketamine and fentanyl or Dilaudid. Depends on the doctor what you're using. So I think I meet in the middle, right? Like I recognize that we're all just one person. So we usually use the same drugs, but we have an open Pyxis. It's not profiled. So you can go in and get the meds that you need, come out, go into the resuscitation room, have one of those rolling computers or computer on wheels, whatever you choose to call it, in the room. right? My expectation is that we have the meds we need. We use closed loop communication on what's going to be given to the patient. And at the end of the procedure, the orders are put in, right? Like you are not leaving the room until the orders are put in. And that's a trust balance kind of issue. There's certainly some of my colleagues that I don't trust as much as others, right? But you can put a nurse in a really challenging place when it comes to those meds, right? So I think that you need to have that closed loop communication to really ensure that you're all on the same page. And then you need to hold the team accountable. So we have done the following things, like when you do your debrief for your intubation, and then you need to check those off. Right. So if you asked me to get vasopressin, a milligram of dilaudid, and ketamine for the intubation or for sedation, I would go and do that. And then when I'd come back, I would never let your rear end leave the resuscitation room until you put it in. Not, Candace, I'm going to go do this, or it's just not tolerated, but I will get in your physical space so it doesn't happen. Right. But that's because there was people that I did trust and I had to chase them for hours. And then being somebody who wears both a clinical hat and an administrative hat, I don't want to have to ask my staff, can you explain to me why you took ketamine out of the Pyxis and 5 hours later you got an order, right? That looks dirty. Those are dirty narcs, right? And nobody wants to be caught with dirty narcs because you really can't explain your way out of it other than pointing the finger at somebody else. So that's how I pretty much make it known. Certainly, there is several docs that are in the room for this. You can identify that the attending is supervising the intubation, a resident is doing an intubation, and the bystander that's hanging out in the corner needs to put the orders in. But maybe you work in a shop that you don't have a bystander, right? So you can't do that. So I think you need to have that sort of debrief when you're done with your intubation, saying, I need the following orders, and they need to be put in the computer now so that I could verify that. It definitely creates a gap when you're barcode scanning, right? Because how are you doing that without orders? And I think that you do need to have that kind of labeling of syringes, accuracy of dosing, that open communication and closed loop, and keeping that kind of the same regime every single time. And once you stray from that is where you're going to have a problem.
What you folks had, but I didn't see being used very often, and it always confused me because it was the perfect solution to this, is there were resus sheets that the nurses could write any orders that were verbally given to them down and then closed loop it back. Okay, so you're saying ketamine 100, rocuronium 100, and they could write that down on that sheet. And at the end of the resus, the doc could sign that. And now it's not a verbal order. If it did get forgotten to be put in the computer, then there's still a record that goes into the patient's chart that these meds were ordered, and that would just save your ass. And I was confused why that wasn't done. I think that's the perfect solution is there should be no verbal orders. There should be a verbally given order that is transcribed in real time. And then the signature of the doctor at the end makes that an actual perfectly acceptable thing. Now, the doc should still go put that in the computer because it makes it easier for the people upstairs to track what the patient got. But if they forgot, then whatever opioids were given during that resuscitation, there's a record for pharmacy that this is not being done without adequate signing. What the nurses did instead is they would usually write it on a scrap piece of paper or a post-it note, all the things, and then give it to the doc of put these orders in. Why were they not using that system of those resus sheets, Candace?
I think since we've gone to the electronic health record, people don't write orders the same way. Like we definitely noticed that with a downtime. It's like you have to write the whole order out. And I think we've been spoiled with an electronic health record. We do have those flow sheets that you can open up, document, and the physician can sign next to it. I do think it creates a little gap if it's in scanned in PDF into the file and then Haley up in the MICU can't see it or doesn't know what was used. So that's part of the reason why they write on those little square stickers and stick them everywhere. That is definitely an alternative.
All right, Candace, this guy gets intubated. He goes to the MICU. He actually does wonderfully, extubated on day 3, and he goes home. We've saved another life. What have we missed, Candace, that you want to get across given the context of this case?
And I think that certainly a swarm technique is the best way to build a team, right? You respect the people that you work with, you know who's going to come and help you, and you conquer the most amount of things in the shortest period of time. And it also gives your colleagues like kind of awareness of what is my specific acuity, right? Oh, Candace has a mass trans post arrest and a septic shock. Very different than I have a rule out a ACS or an NSTEMI that's not going to the lab, right? Like very different sets of patients that you're going to take care of.
All right. Well, Candace, I think this is a fantastic first episode. I very much enjoyed it, and I hope the people listening will as well. So say bye-bye.
See ya.
There you go. First episode is a wrap. Now, we have this as one of the formats, this case-based. We're going to have other formats as well. But for this first one, I would love to know, Candace would love to know what you think, what your feedback is. Was this good? Was this what you were expecting? Was this what you were excited for? Can you think of ways to make it better? Or was it just fantastic and we should keep going along these lines? This is the beginning stages. We need your opinions, please. The best way to get the opinions to us is put them as comments on this actual episode page at EMCrit.org. But, we'll take them however we can get them. If it's Twitter or LinkedIn or what have you, that's fine. But better would just be go to EMCrit.org, find this episode, and put the comments right there, because then we could all see them and we could all get better and we could all make this exactly what you want it to be. Scott Weingart for Candace King and the One-to-One Nursing Podcast saying bye-bye.